Yeah, looks like it's doing good.
All
Nice.
right. Thanks for coming, everyone, and taking time out of your evening to listen in. This is Johnny Barba. He's an M4 here at OSUCOM, and I probably don't, I couldn't give him a fair introduction with all his accolades and how accomplished he is, but he is very passionate about rural health. And today he's going to share with us some of his experiences and what he's been doing. So take it away.
Hey, thank you so much for the heartfelt introduction. I'm just so, blessed, honored, and grateful to be here today. And just thank you for inviting me out and setting all this up. So, without further ado, my name is John Carbarber II. I did my master's of public health here at the Ohio State University, and I'm also a fourth year medical student going into dermatology. So, I cannot wait to tell you about overcoming Appalachia's mountains of health disparities, one small stone at a time. And I'm going to apply this with the three P's of Appalachia. And you may know Appalachia is only spelled with two P's. I spell it with three P's because really I think it's epitomized by its place, poverty, and people. And while I've given this talk in different forms, I've given it as the medical student grand rounds, and I've given it different forms, I really made this a unique talk. I've picked and choose different aspects that I really think speak to what I really wanted to get across with the Rural Health Initiative, and I'm going to apply all of this overcoming Appalachia's mountain health disparities to melanoma and apply the three P's framework to explaining the disproportionate rate of melanomas in rural Ohio Appalachia. So without further ado, let's jump right into this. So got the little bird flying off of there. So let me introduce you to the Appalachian region. It spans 13 states. And as this map shows, this is the entire Appalachian region. And it spans all the way from southern New York all the way to northern Mississippi. So it's a quite large area. And really, it is, I should say, I'm from right here. This is Guernsey County in rural Ohio, Appalachia. I'm a first generation student from that little county right there. I'm from Bisell, Ohio. And you may know Cambridge, Ohio, if you traveled through 77, Interstate 77, or Interstate 70, because they cross right in my hometown. So that's Guernsey County, where I'm from. And really, the whole ideology behind the Appalachian region is that is geopolitically defined. And what does that mean? So it's defined by geo or geography. It's defined by the Appalachian mountain terrain, and politically because of different certain characteristics of the 420 plus counties that compose this entire region. Moreover, this area is disproportionately rural. 42% of the land is rural versus 20% of the nation, and it's home to 8.2% or 26 million Americans. Appalachia is also home to numerous health disparities. And let me show this map to you. So you're looking at here on the screen is cancer rates in rural Appalachia as a percent difference in mortality rates in Appalachian states relative to urban non-Appalachian states. And so you can just see the health disparities are really popping off the screen at you. You got Ohio here with plus 15.5%, and then you got Kentucky 36%. You can really see the disparities just popping off the screen when it comes to cancer rates in rural Appalachia. And moreover, I put some summary statistics down here that Appalachians have higher mortality rates than the nation for 7 of America's leading causes of death, including cancer, suicide, diabetes, stroke, cardiovascular disease, injury leading to death, and chronic obstructive pulmonary disease. And if we apply this to melanoma and talk about melanoma disparities, this is a really nice study that was done between 1996 and 2003, showing the different types of cancers among those in rural Ohio Appalachia, or excuse me, in terms of all of Ohio Appalachia, there's 88 counties in Ohio. 32 of those 88 counties in Ohio are in Appalachia. And so you can see here that the melanoma disparity is much higher in terms of incidence, in terms of percent difference in mortality as well. Moreover, this paper goes on to note that over 20% of Ohio Appalachians' melanomas are diagnosed at a later stage. And really, I've shown you all of these health disparities. And I remember sitting in my second year of medical school before I ever decided to do a master's of public health, and we had these social determinant of health lectures. And I remember them showing me statistics like these that I just shared with you on the screen for some of our lectures at Ohio State. And I just remembered the weight of my chair just like pushing on me. And I just remember being like, oh my gosh, like I did not realize the health disparities in my hometown region. To me, that was just normal life. I really didn't know how bad all of this was. And that's why I really put this quote in here. I wonder how many people I've looked at all my life and never seen. You know, when you see numbers and statistics, do you just see the numbers and statistics I just shared with you? For me, I see my family, I see my friends, I see my fellow Appalachians represented in those statistics. And that's why I'm so passionate about going back home and pioneering a rural academic residency model, which I'll tell you about later in the talk. But really, those numbers and statistics speak to themselves that we must do what we can to overcome those mountains of health disparities. And so let me apply those three P's framework of place, poverty, and people to melanoma and give you a little bit of framework about what this framework really speaks to. So let's start with place. The place Appalachia is defined by a lack of healthcare services, hard to navigate rural terrain, longer transportation times to healthcare services, lack of public health infrastructure, and more Medicaid enrollees. And if you just drag your eyes along the screen and you look at the screen here, this looks like Trail Run, an area close to me. I found this online. It really epitomizes what rural Appalachia looks like in my mind. And so if you drag your eyes along the road here, what do you notice missing? There's no sidewalks. So when you tell your patients to go out and walk for their health, where do you want them to walk? There's no sidewalks. Moreover, look at this. Just drag your eyes up and down the screen. You see how mountainous this is. It's really, there's not a level place to walk. Moreover, you might be like, well, why can't they just drive the healthcare services? Well, look at cars like this. Statistics show that Appalachians may own vehicles, but the vehicles they own are of less quality, they're older, and usually less operational. So there's really so many barriers. Moreover, there's a lack of public transportation. So how are folks expected to get to care? So that's really the place of Appalachia. And if we apply this to Breslow's depth and melanoma, that's what's shown on the screen here. And for those unfamiliar with Breslow's depth is what is used to prognosticate melanoma. So basically, the deeper the melanoma is in the skin, the worse prognosis, which is very intuitive. And so the deeper the Breslow's depth, the worse prognosis. So let's apply that to place. So Breslow's depth increases by 0.6% per mile traveled to a dermatologist. Moreover, urban regions have 40 times the concentration of dermatologists versus rural areas. And if you just broadly look over all specialties, there is 65% less specialists in Appalachia and 30% less PCPs in Ohio Appalachia. And so these really speak to the place that Appalachia is. All right, so let's go ahead and talk about poverty. So in terms of poverty, you can look here on the screen. Appalachia is in yellow and the United States is in blue. And as you can see, all the way back from 1960 all the way to 2019, there has been persistent and historic poverty differences between Appalachia and the United States. And poverty really financially disadvantages and restricts residents from accessing care, their social mobility, and it contributes to the negative provider stereotypes about patients in this area. Moreover, I'll show you some income inequalities. So Appalachia is in yellow, the United States is in blue. This dates back from 1969 all the way to 2019. And I want you to look with your eyes. Look how close the graph is right here. Now just look. The graph is widening. It's not getting closer together. The graph is widening. So there's a widening disparity in terms of income inequalities between Appalachia and the United States on a whole. Moreover, if we look and we think about poverty in terms of educational attainment, I'm very blessed and honored that I was able to go get a bachelor's degree, that I got a master's degree, that I got a medical degree here coming up in May. It's just kind of mind-blowing to think about where I come from and to be able to even sit in this chair and have this conversation with you all today. It's very humbling and I'm very blessed for that. And if I walk you through the slide on the screen, I'll tell you, the statistics really say, I'm an anomaly even having this conversation with you all, because if you look all the way back from 1970 to 2019, there's been persistent less educational attainment in Appalachia in terms of bachelor's degrees and, of course, more professional degrees. And so really this speaks to the poverty of the area, right? Because think about it. If you're your family and you're growing up in all these poverty, statistics and things like that, and I'll level with you all. I grew up in a single parent home. My dad passed away 2 weeks before I was born. And so really when you're a part of this, I grew up on Medicaid and HUD housing and food stamps and governmental phones. I know what it's like to live that life. And really the pressure to just get a job, start making money, start giving back to your family financially, it's a huge weight to bear and a huge, pressure. And so how can people, a lot of people say, oh, go to college, explore your interests, change your major 13 times. I don't know if people from Appalachia rural areas really have that on the menu of their mind as something that's possible, because I just showed you all these statistics. There's such a pressure to get jobs or multiple jobs straight out of high school and start financially contributing to your family, or even while you're in high school. And so that's something that really, I think, plays into these statistics that the graph doesn't, so to speak. And so if we keep looking at this, and I pull up childhood poverty rates, I want to share that with you quickly. So this table here shows the state of Ohio, the Appalachian region on average, and rural non-Appalachia. And what really I want to draw your attention to is the amount and percentage of children in poverty. The Appalachian region has one of the highest, if not the highest, percentage of children in poverty. Moreover, at the Cambridge City School District, the school district right here in Guernsey County, 95% of the students 95% of the students live below the poverty line. That sounds like a made-up statistic, doesn't it? That is just incredible and speaks to the poverty of the area. Moreover, as you can imagine, there's high Medicaid enrollees for these children and high food stamp enrollment for these children. And I certainly was a part of these programs, and they certainly have made my life and my possibilities possible by really financially supporting myself and my family through these times. And really, when I was studying this during my Master's of Public Health, I came across the study called the Adverse Childhood Events Study, or no, Childhood Adverse Childhood Experiences, the ACE study. And if you haven't got a chance to read it, I really recommend going and reading it. And it really talks about things such as poverty and divorce rates and things of that, leading to long-term health sequelae, such as mental health disorders, cancer, diabetes, less educational attainment, less income attainment. And so I really summarize the study by saying early beginnings have lasting impacts. And for those of you who may have had the chance to study like epigenetics, I really task you to think about how those epigenetics might change based on early childhood experiences and how those can have early beginnings and lasting impacts. And so I really wanted to bring us back to this slide before I move on from poverty. We talked about the historical and persistent poverty in the area, but that wasn't enough just looking at Appalachia versus the United States as a whole. I really wanted to stratify that out by rural and rural Appalachian regions. So if you stratify the average poverty rates in urban areas, that's about 12%. If you stratify that out by rural America, which on average is more poor than urban America, you see that poverty statistic go up to 16% on average. If you stratify that further out, just by the rural Appalachian counties, that poverty statistic actually becomes the highest. So Appalachia has the highest on average poverty rate of anywhere in America. And so that is the poverty of the area. And if we apply that to melanoma and Breslow's depth, as we were talking about, tying this all back into melanoma, Breslow's depth increases by 1% for every 1% increase in poverty. Moreover, the average poverty rate ranges up to 41% in some Appalachian counties. So you can imagine the health disparities of those melanoma statistics that we talked about in the beginning. All right, so that's poverty. Let's move on and talk about people, the final P of Appalachia. So people, really, it's about the culture. It's characterized by collectivism in Appalachia with a sharing of information and resources within close-knit networks that protect their own and could be distrustful of outsiders. Moreover, studies have shown that Appalachians are less satisfied with the quality, the information, the courtesy, and convenience of their health care. And if we apply this to melanoma, we have to put it in terms of sunscreen and prevention. So rural residents are 33% less likely to wear sunscreen and 82% more likely to use tanning beds. Moreover, on a sunny day, 21.4% of Appalachians versus 27.4% of non-Appalachians report wearing sunscreen. And I put it here in the brackets, survival mindset. And what do I mean by that? So I just got done telling you about those poverty statistics and how there's such financial strain on folks in Appalachia. And do you really think they're budgeting in their mind that they want to buy a preventative product such as sunscreen that may prevent skin cancer down the road in some distant future? No, we have to care about the here and the now. We have to take care of today. They have to live for today. And so not having the ability to really, if you study like Maslow's hierarchy of needs, and you've looked at that, how people need food and shelter before they can go on to have like other, human disease, human desires and things like that. And once it's because they're not meeting those basic needs. So if people aren't able to meet the basic needs of putting shelter, putting food on the table, they can't even think about buying sunscreen or preventative product that may prevent sun cancer or skin cancer down the road. They really have to take care of the here and now, and that's really the survival mindset. And in this area, and we talk about all the lacks of Appalachia and all the lacks of rural region, I really like to talk about what Appalachia in this region doesn't lack, and I like to talk about the region's most valuable resource. And you may have guessed it, but it is the people. People are really the region's most valuable resource. And that's why there's such collectivism. There's such teamwork. When people ask me about teamwork and leadership, I say I grew up in the most teamwork heavy environment you possibly can, where families share firewood, they share meals, they share a helping hand. People in Appalachia sincerely value one another, they appreciate one another, and they work together to survive in this area. And so I write up here that while Appalachia is poor financially, is extremely rich in culture, collectivism, family values, and faith, making people the region's most valuable resource. And moreover, I wrote here Appalachian Life Course Perspective. And if you get a chance, please, please, please go read a paper. It's by Braveman. And he talks about the life course perspective. And I know when I was studying certain diseases and pathology in medical school, I really didn't understand the roots of some of those diseases. And I'm like, I feel like something's missing. And if you had those feelings during your first or second or even third years of medical school, I really challenge you to go read Braveman's Life Course Perspective. And it really fills in those gaps of talking about those early beginnings, those adverse childhood events having lasting impacts. It really talks about how somebody and all the different things that their life has gone through to this point in time when they're seeing you in the doctor's office that led them to that that moment. It really explains the pathophysiology of disease in such a manner that I could not find anywhere else in my study. So I really challenge you to go read that paper. And so I write here, in a region filled with environmental and social injustices, what would you do to protect your most valuable resource, that being people? Understanding this enables one to appreciate the unique culture of Appalachia, where folks function in close-knit networks to survive, where trauma is normalized, where people are just trying to stay alive. And by understanding that, you really understand the culture of Appalachia. So now that we've talked about the health disparities of Appalachia, it's one thing to describe the problem. What I'm more interested in is, what are we doing to address the problem? And during my Master's of Public Health degree, I did that in health behavior and health promotion. I did it along the addressing health disparities track. I would do it 30 times again. If you're ever thinking about doing a Master's of Public Health, absolutely do it. And I would recommend you doing it here at The Ohio State University. I had excellent education. And so I really thought about, how would I address these rural health disparities? And I really took my entire Master's of Public Health to design novel ways to do that. And so really what it came down to, and how you address rural Appalachian health disparities, it is simply as such: bring the medicine to the people, bring the healthcare to the people. And so how can we bring the healthcare to the people? I got to design different projects and programs. So let me tell you about Patch It Up. So welcome to Patch It Up. Your flu vaccine patch is here to keep you healthy during this flu season. Open this brochure to get started. And so, what is this? You're like, Johnny, what are you talking about here? There's no such thing as a patch vaccine. Well, the last time I looked it up, it's in phase 3 trials. And essentially, it's shown really nice here in this diagram. It's basically a Band-Aid with microneedles on it, and it has the flu vaccine. And all you have to do is simply place it on the skin, leave it on the skin for a certain amount of time, and then remove it. And you're fully vaccinated against the flu with equal efficacy to a normal intramuscular injection of the flu vaccine. While it's not yet available, hopefully it will be here in the coming future. And the really interesting thing that these authors did with this is they actually showed that you can actually mail this patch vaccine with, the heat, the cold, the different conditions, not affecting the effectiveness of that patch. And so really, that's why I like to have this little man jump into the screen here, because this is a mail-based delivery of care. Imagine this: you can mail somebody their flu vaccination. And I remember during the COVID pandemic and all of this, people were like, why are there such lower rates of vaccine uptake in rural areas? And there's a multitude of reasons for that, visit vaccine hesitancy being among them. But one of them is, there's just no place to get it. There's a lack of pharmacies. There's a lack of healthcare providers. There's a lack of places where you can actually get the vaccine itself. So imagine being able to just, mail the COVID vaccine, mail the flu vaccine to people's homes, and just right in the mail, and they could do it right from home. And that's what I think really what it means to bring healthcare to the people. And this is one example of a mail-based delivery of care. Let me give you another example. So what about cervical cancer screening? In Appalachia, cervical cancers are diagnosed at a later stage. There's a higher rate of cervical cancers, and those that are diagnosed at a much later stage, and they're much more invasive, and that leads to the higher mortality rate from cervical cancer in the Appalachian region. But really, what is the root cause of that? It's the lack of screening. Screening is so important for cervical cancer. And so how can we overcome the lack of cervical cancer screening in Appalachia? Well, this Evelyn brush is one idea. And if you've not heard of the Evelyn brush, it comes with directions like this, and you can mail it. This can actually be mailed in the mail to somebody's house, and they can actually, swab the cervix, get cells, send that back in, and have their cervical cancer screening completed right from their home. And so that's such a powerful way to bring the healthcare to the people, is just by mailing it to them and letting them collect these specimens. Moreover, there's something called a pocket colposcope. And if you've come across this before, this wouldn't be to send somebody's home by mail-based care, but you could send it to rural clinics and rural healthcare sites. And basically, it's an instrument that's really, as they put here, the potential to revolutionize cervical cancer screening in low-resource settings, because you can use this to take images of the cervix and then send it virtually to experts somewhere else. It's basically a form of telehealth and communication for that, for the clinicians themselves practicing in these areas. But all of these really come down to bringing the medicine to the people, and it's by mail-based delivery of care. And so that's why I bring in our little mail-based delivery of care fellow coming in here, showing you that these things can just be brought to the people's homes. Let me give you one more example. So on the screen here, we have colon cancer screening with a colonoscopy, and that's so important, right? There's higher rates of colon cancer in Appalachia. There's higher mortality rate from colon cancer in Appalachia. So we really much find a way to bring colon cancer screening to the people, but you just can't bring this. You can't bring, a colonoscopy to the people. What can you actually bring to the people? And that was a challenge for myself when I was reflecting. And as some of you may have thought, well, why don't you just send them the FIT test? I 100% agree with you. You can send them the fecal immunochemical test, and they can just rub a little bit of stool on the test here, and then they can have to see if there's certain antigens are detected or blood detected, and it may provoke them to then be able to drive that 2 hours to go get their colonoscopy. And if you think about the things that we learn, and if you ever get to do a Master's of Public Health, they love the stages of change model. And even in medical school, we get tested on the stages of change model. It's on your step exams, it's on your in-class exams. And so the stages of change model, if you think about it, what if you sent this test to somebody's home? You just mailed it to their home. They do it and they get a result that's abnormal. I wonder if that would help people go from the pre-contemplation to the contemplation to the action. So those different progressions along that. Somebody who's like, I'm not driving 2 hours and I don't want to go through all that prep. I don't want to do all this. But now they have an abnormal test that they got in their own living room and they're like, maybe I should drive that 2 hours to go get my colonoscopy. Maybe I should, do this. And I really think it'll help progress people along that stages of change model. But all of it comes down to bringing healthcare to the people. And this is another form of mail-based delivery of care. And so I thought about mail-based delivery of care. And when I was thinking about, mailed, actual physical mail, I thought about virtual mail as well. And virtual mail to me is categorized by telehealth. And certainly there's opportunities for telehealth, but there's also notable challenges. I'm sure you guys who are interested in rural health, whenever you start talking about rural health, people always love to bring up telehealth. And telehealth certainly has a role, right? It can bring care to people many, hours, states away even, to be able to bring them care right into their home. But there are limitations to telehealth, and I think it's really important to understand those limitations. So let me tell you about them. So there is actually a lack of telehealth capabilities in the Appalachian region versus the nation. And why is that? Well, there's 5% less ownership of electronic devices in the Appalachian region. Moreover, there's 6% less internet subscriptions and access due to geography and poverty. And what does that mean? Well, think about that first picture I showed you about those winding hills and the mountainous terrain. How are you going to build internet towers on that? It doesn't happen. And so there's a lack of access to internet subscriptions because simply the geography prohibits the building of them. But actually, a lot of places like the Foundation for Appalachian Ohio and many other amazing foundations are really coming together and starting to build those towers and overcome the mountains of Appalachia to bring internet services to people. Moreover, the poverty of the area and being able to even afford, internet subscription, even to be able to afford the electronic devices. We have them all over. I have my phone here, an iPad, this computer. That's such a lack in Appalachia. People don't have the funds to be able to afford these kinds of things. Moreover, if we just stratify out, this was the entire Appalachian area. If you stratify out just the rural Appalachian counties, or the rural places in Appalachia, there's 11% less ownership of electronic devices and 13% less internet subscriptions and access to the geography and poverty. So you can see that disparity, even within the disparity of Appalachia, even more so for rural Appalachian counties. And when I think about telehealth, it really reminds me of when the pandemic started. And in Bisel, Ohio, there's one stoplight and there's a McDonald's. And I remember right when COVID started and, all the schools that kind of shifted to virtual platforms, if you drove past the McDonald's on a given morning right when the COVID pandemic started, you'd see 50, 70, 80 cars around the McDonald's. And you know why they're all around the McDonald's, right? Because people have to drive in from these rural areas where there's a lack of internet to go and set up McDonald's where they can log on to the internet to be able to do their virtual classes. And I think that's one limitation of the telehealth. Some people are like, I don't know why telehealth doesn't work in these rural areas. Well, people still have to travel to a location to where they can access internet, number one. Number two, they have to have a device where they can actually be able to access internet on it. And number three, they have to be comfortable actually using that technology to log on to that telehealth mean to actually have that conversation with providers. And so for all of these many reasons, these are the limitations of telehealth that I hope you keep in your mind. It is a tool in our toolbox, but it's not the solution to all of those disparities. But what is the solution to those disparities? What can actually overcome those telehealth barriers? Why not good old in-person medicine? And I think the folks in Mississippi really hit this on the head when they started designing something called DREAM. And this is the Dermatology Rural Education and Access Model. The DREAM model is written by Dr. Burdell and Dr. Bird, who are amazing people pioneering rural dermatology and rural residency models within dermatology. And so let me tell you about this. So this is a little map of Mississippi here. And right here in Jackson, Mississippi, this is where the main University of Mississippi is. This is where all their main dermatology offices are, where their main, this is like their Ohio State is in Jackson, okay? And then about 2 hours away in Louisville, Mississippi, a more rural area in Mississippi, that's where Dr. Bird practices, and they have a satellite clinic there, and he actually has a rural dermatology resident, a resident who spends 3 months out of the year, each year, training in rural dermatology with him, getting a continuity experience in rural dermatology. Then for the other 9 months of the year, they train in Jackson, Mississippi, in a little bit more urban setting. And so really what they tackled that is if people cannot come to the medicine, bring the medicine to the people where the people are actually living. And Dr. Bird, he has such a heartwarming story. This is actually where he grew up in Louisville, Mississippi. This is where he went home to practice, literally caring for, the friends and family in that area and his community, which is such a powerful story. And, I was very honored and humbled. I got to go down there and actually rotate with Dr. Bird himself. This is my rural dermatology away rotation in Mississippi. And if you're considering rural dermatology or considering dermatology at all, I really highly advocate that you consider going down here to Mississippi and rotating with these folks. Just an incredible learning experience. So this is me holding that paper that I just cited right here on the screen with Dr. Bird, who helped write it. And this is his rural dermatology resident, Dr. Benjamin Rushing. And so just incredible people down there, the kindness, and just you will learn so incredibly much. And in fact, it's very hands-on. So if you're somebody who's very procedure oriented or very want to do things oriented, really want to take ownership of your patients, they really prepare you for that. And how do they prepare you for that? Simulation. So my first day there, and this is a picture of me with a pig's foot with some suture in it, and you're like, oh my gosh, how is Johnny going to tie this in? First day there, they say, Johnny, go down to the local butcher. They're going to be expecting you, and we want you to pick up some pig's feet. I'm like, pick up some pig's feet. What are we going to do with this? So I brought it back, and Dr. Bird, sat me down. He took out a little knife here, and he made some incisions, and he says, go ahead and do a simple running suture and repair them. And once you do them adequately on the pig's foot, I'll let you do it on people. And I did just that. I got to learn how to really kind of tweak my suturing techniques, and then I got to actually do that on real live people, and I really felt much more prepared and much more hands-on to be able to do suturing because I got to really do it and learn it. And so just an incredible experience. If you're really thinking about dermatology or rural dermatology, really advocate for you consider going down there in Mississippi. You won't regret it. It's an amazing experience. And so that is their experience, and this is kind of their model. How can we then overcome the mountains in my own area? And I kind of reflected on how they related to my own goals. And really what it came down to is this question right here on the top of the screen. And my answer to that is view mountains as opportunities and not obstacles. And so let me bring up that map that we began with. So here's that map of the Appalachian region. There I am in Guernsey County. And I started to think, this is my Jackson, Mississippi, right? Or excuse me, Columbus is my Jackson, Mississippi. Cleveland is a Jackson, Mississippi, right? And this is my Louisville. Guernsey County, Cambridge, Ohio is my Louisville. So what if I could create a rural academic residency model and bring the medicine to the people in my hometown? I really want to be in academic medicine, and I really want to, stay in academia. And I'm thinking, how can you do that in a rural area? Well, it's by doing what they did in Mississippi, by creating a rural academic residency model. And so really, and it really matches up nicely with my area. In fact, we have the largest interstate intersection in the entire world. Despite being a small little rural town, Byesville is 2,000 people, Cambridge is about 10,000 people. Despite being a little small rural town, we actually have the largest interstate intersection in the entire world. You can Google it if you don't believe me. I couldn't believe it myself. But by saying that, you can go north or south on 77. So a lot of people funnel up from Kentucky, West Virginia, Pennsylvania. They funnel up 77 to Cleveland to get care, or they funnel across 70 to go to Columbus at the Ohio State University to get care, or they go east, maybe down here to Morgantown or Pennsylvania to get care, or they go south. But the key point is this is a key interstate exchange area, an ideal catchment area to bring the medicine to the people. And so I want to take that rural academic residency model they have in Mississippi, and I want to create it right here in rural Ohio, Appalachia. And really, it comes down to viewing our mountains not as obstacles, but as opportunities. And so with that, I really wanted to just take the next few slides to just briefly cover how I think you could do rural academic medicine if you're somebody very passionate about academic medicine, such as I am, how you can continue to do that. And it really begins with me, being a first aid author, which really started with just refrigerator YouTube videos. And so let me explain what I'm talking about. So during your MSK block, you may have came across this crazy guy on YouTube drawing on his refrigerator, such as this here at Ohio State. And that was me. That was me. This is Johnny on the Spot, USMLE. And this was me drawing my very first video. This was a brachial plexus that I drew. And what I didn't know at the time is this would actually lead to a position with first aid. And eventually, that's what happened. I ended up applying for a position and getting accepted to be an author for first aid, and they let me create 30 Step 1 Video Express lectures. And I was very honored to have, among the highest rated content on the platform. I got promoted to Author of the Year, and I was very honored and blessed for that. And then I got to help compose the USMLE Step 2 CK book and help write in 4 to 5 chapters in this book and edit the entire book. Actually, if you guys like visuals, I got it sitting right here beside me. I definitely look up things in it as I'm studying for my emergency medicine shelf coming up. So it's a great resource to use for sure. And then also I help write with flash facts. So if you ever use those, step one flash facts. And really, I like to do things on Twitter too. And this is just my, hey, it's Johnny on the spot USMLE review. But all of this is to say, I have very rural interest. And I did most of my master's of public health, and then I did a year of medical education. I did most of this work during my master's of public health or during that year of medical education. And that's all to say, I did it right where I'm sitting today, right here in rural Ohio, Appalachia. And I just reflected on that. It's like, oh my gosh, you could be in academia. You could publish in these amazing, textbooks. You can collaborate with people across the entire, United States and across the entire globe for that matter, right here in your small little rural town. So if you're somebody who's interested in rural academic medicine, I think just by taking this, I hope this gives you some inspiration that you can do whatever you would want right from your small little rural town. And that's what my reflections on first aid remind me of. And so I also want to talk about creating public health infrastructure. If you looked at that first screen when we saw that road and there was no sidewalks on the side of the road, right? It's like, where do you want people to walk? And that's what really struck me during my master's of public health. And I was walking through the park with my little cousin Emmy. She's right here on the screen. This is my cousin Emmy, my aunt Rosie, my mom Mary, and my cousin Kayla. And this is me being silly with my little cousin Emmy. And in fact, you can see me on the screen. This is her on that disc golf disc I had printed when I got an ace there at Muskingum University. And really, we were walking through the park one day and she's like, John, this would be a great place to put a disc golf course. This would be a great place to have people get out and be healthy. And I was like, oh, yeah, it would be. And she's like, Johnny, why don't you do it? I'm like, what do you mean, why don't you do it? My mom was like, yeah, why don't you do it? Aren't you getting your master's of public health and grant writing and program planning? And I was like, you know what? Right. I don't have to wait. Like I always thought, oh, you need to wait until you get into your career to, really give back to your community. I've been doing other community service, but nothing on this scale. And so that night we got some inspiration, and we, over a course of a month or so, we designed this map I'm showing on the screen now. And so this is the Cambridge City Park here, and this is all the disc golf course holes. Here's hole 1, 2, and you can see them going so forth. And we presented to the Cambridge City Park, a way to put in this disc golf course. And then Dunning Motor Sales here at the bottom was a philanthropist here in local town. He helped fund the course. But also I used my grant writing skills for my Master's of Public Health. We've raised over $70,000 actually as part of something that I call the Dr. Disc Golf Initiative. That's my little logo here on the screen. And so as part of the Dr. Disc Golf Initiative, I used my grant writing skills to apply for grants, and we've raised over $70,000 to install over 100 baskets across 3 disc golf courses. Let me show you those disc golf courses. So here's Chasing the Chains. That's the first one. And one thing I'll note about this one that I really like is that there's a paved walking path, and we also have concrete tee pads. So people with even wheelchair accessibility needs can get out and go right on the pads and play with everybody else, getting out and enjoying the beautiful nature and fellowship with one another. Moreover, here's Whitetail Trails, Salt Fork Disc Golf Course. If you're ever out at Salt Fork, it's a beautiful area, such beautiful mountainous terrain and wooded areas. We have the Fawn Course, which is for beginners. We have the Doe Course, which is the intermediate course. Then we have the Buck Trail, which is the advanced course. And I should call them Fawn Trail, Doe Trail, and Buck Trail, excuse me. So Whitetail Trails. And so we got to put that course in. And then this is the Paws to Claws Cambridge City School District Disc Golf Course. We just put this course in. I'm actually speaking with their community advisory board and the leadership of the school tomorrow about this course, about our grand opening. But this is another course that we put in, and this course was put in as part of the 21st Century grant that I helped apply for and help write the statement of needs for, and really give back to our community and raise money. And really, all of these courses, and why I'm sharing this, like, why are we talking about disc golf in this, Johnny? It's really because it reminds me of one of my favorite quotes by Walt Disney. And that is, the best way to get started is to stop talking and begin doing. If you're passionate about your rural health communities, if you're passionate about all your communities, figure out ways to start giving back to your communities now. I could have never imagined I would install 100 baskets of disc golf across my, areas back home and give back to my community while still being in medical school. But just by taking that initiative, by having a little cousin like this and my mom and my family supporting me, it's really, comes down to community of support. And one thing I'll say is, like, these courses, this is definitely a we and not a me. I have had such tremendous support, even at the Chasing the Chains. We had local farmers drive their tractors in the town. We have a little post hole digger on the back that puts in the disc golf course. And all of these are just the product of so many people helping to run leagues. We do mentorship events. We hand out healthy snack bags. We hand out sunscreen. We partner with local schools like the Cambridge City School District, who now has their own course, to really be able to give back to the community in terms of mentorship and fellowship with one another. And so disc golf means so much more than just those plastic discs, throwing them in the chains. And so that is the Dr. Disc Golf Initiative. And I hope it inspires you to see there are just so many ways to get back to your community and get involved in your communities back home. All right, so to close with that. So this is a little motivation I like to say is going to be day one or one day. win the day. And what do I mean by this? So this picture right here, this is in Seattle. I took this from the Space Needle. This is Mount Rainier, and this is when I got invited out to the American Academy of Dermatology Innovation Academy as part of the Rural Access to Dermatology Society to give a version of the talk that you just listened to today. So I was very humbled, very blessed, very honored as part of the Rural Access to Dermatology Society to go out there and speak about these things. And I remember being up there at the tower at the Space Needle and reflecting on this, and really this is what came to mind. Is going to be day one or one day? Is it going to be, one day I'm going to give back to my community? One day I'm going to go do this? Or is it going to be, today's day one? I'm going to go, maybe there's a service project in your mind right now, or there's somebody that you haven't called back home, or there's a family or friend, or any way that you can give back home. And I will say, like, one of my favorite life quotes is the do small things with great love. The best small things you could do with great love is put a smile on somebody's face, lend a helping hand, call that person up that you might be thinking of, call about that service project, call about that research project you're interested in, anything that really inspires your heart, and make it day one and not one day I'll do this. Today is that day, my friends, and I hope you're inspired to win the day and do what you can to give back to your communities and be inspired to go practice in these rural environments. And so, with that, I will just say I believe that by working together, we can overcome any mountain in our way. And I would just leave this screen up here. This is my YouTube channel. If you're interested in watching some of my other content, feel free to scan this QR code. If you're interested in the Rural Access to Dermatology Society, please scan this QR code here. It's free to join. And if you're going to the American Academy of Dermatology meeting in March, I will see you there. Please come and see us, and there's some more information on there. And as always, feel free to reach out with me. I'd love to schedule a phone call or anything with you guys, and just be able to give back to all the amazing mentors that have given me the opportunity to pursue my life stream. So with that, thank you all for your time. I'm very humbled, blessed, and honored to be here. And I'll take any questions if you all have them. Thank you.
Wow, that was great, Johnny. Thank you so much. I will give everyone else a moment to ask some questions if they have any. I do have a couple I thought up of, but we'll see. Okay, I'll start. You touched on telehealth, which is great because I feel like telehealth is the first thing that a lot of people jump to. And interestingly, one of the surveys I looked at, I think it's the Ohio Rural Health Plan Improvement Plan. There's a lot of community resistance to telehealth, and frankly speaking, of my experience in the clinical in clinical rotations, I'm not convinced that telehealth is high quality care for a lot of specialties. And so, to me, it's a little bit of a band-aid to a more systemic problem. And I was wondering if you had any thoughts, or, you've been to a lot of great conferences and participate in a lot of great discussions of any sort of other systemic, changes to recruit more physicians or specialists to practice in these areas outside of that residency program, which is really cool to hear about.
Yeah, I love that. Thank you for asking that question. Thanks for sharing that data. I've come across those same kind of things of like the resistance to telehealth, and I think people ask us like, why doesn't telehealth work? And it's like some of those things I shared, the less internet access, less electronic devices, kind of the resistance to it. And really, that's what I think it just comes down to. Is it really nothing overcomes just bringing medicine to the people and physically being in these communities, living in these communities. I've grown up in Cambridge and Byesville, Ohio, my entire life. It'd be the biggest honor of my life, and it will be when I get to go back home and practice there. And really, I know these spaces. I know the people here. I know the things they face because I've lived in this space for so long. And I think that really speaks to how you overcome these places. You need to recruit people from these underserved areas and incentivize them in ways to go back home and practice. And I think that rural dermatology residency program in Mississippi that they have is one great way. A lot of their rural residents go and practice in other spaces in rural Mississippi because they feel so empowered and so prepared to be able to go and practice in the demands of a rural underserved area where you're going to be able to have to access and treat a large population with very, different psychosocial needs and things of that nature. One that really comes to mind that you think like with telehealth is like even people with like biologics. Like if you're going to prescribe a biologic and it needs to be refrigerated, some people in rural areas don't even have refrigeration. They don't have electricity. So it's like, you still have to have a place where they can have that biologic come into and get it refrigerated. They still have to come physically to get the medicine, right? And so I think really the bottom line is like, telehealth is a great tool. It's a great, thing in the tool belt. It works great for some patients, other patients not so much. I think it's about really having that one-on-one with your patient, developing their treatment plan, really understanding their life course perspective, really understanding their social determinants of health to be able to best provide their care. But I think it comes down to recruiting folks like you and I who are very passionate about rural health and going back home and practicing and thinking that, hey, I could still be a part of a larger academic center. It just might be 2, 3, 5 hours away from the large academic center, but I could still be in academia. And I think that would be quite enticing for people to be like, oh, I could still be in academic medicine. I could still, be a part of these organizations, but yet be practicing in my hometown. I think that's really where the power lies.
Yeah, thanks for mentioning that too. I tell, some of my mentors or, the physicians I'm rotating with that I'm interested in both medical education and rural medicine. And it's kind of like this juxtaposition in everyone's head, but I really don't think that has to be.
Yeah, exactly. Exactly. I don't want it to be. I hope that, like they're doing in Mississippi and like we're having this conversation. I really hope that changes. And, people don't think you're either in academic medicine or you're in rural medicine. It's like, no, you can have rural academic medicine. And I really hope, inspires you and myself, to know those are possibilities and to go back home and practice. So I love hearing that. And I advocate for you on your rotations. Tell them you're going into rural medicine and, tell them you really need to be prepared and get fully immersed in the setting you're working in. And that's always day one of what I tell people. I'm going to go work in a rural setting. I need to know as many tools that I can gather now so when I go home I can really provide the best care. So that's like my fully immersive approach to my rotation. So it sounds like you definitely do that as well.
Great, thank you. Anyone else have any other questions? Looks like there's one in the chat from Autumn. Um, Thank you. This was a great talk. I'm from Wheeling, West Virginia, so I think I passed through your county on my way home. How did you gain community engagement and spread the word about your initiatives? I think I'm interested in giving back in a way you have now.
Yeah, I love that. Incredible. And thank you, Autumn, for the comment. And also thank you, Lori, for your comment too. That's very, I appreciate your kind words. And really, when it came down to community engagement, in small towns, you really, I feel like being a part of a small town is like being a part of a larger family. That's what I always tell people. And in Appalachia, the lines between friends and family are quite blurred. And by saying that, it's like really networking in your communities. Like I grew up in my community here, and I was like, okay, at the Cambridge City Park, I'd really like to put in a course. And I started asking, I asked my Aunt Rosie, I asked my family, who's in charge of the park? How do I get? And then I got a hold of the leadership there. And it's like, oh yeah, I know so and so, and so and so knows so and so. And oh yeah, we know your family. We know this friend. We had this connection. Yeah, Johnny, come on in. We know you're from this area. Come on in. Come talk to us. And then I developed a presentation and developed a plan. And I think that's really, the key thing. And I will say in like a rural area, if you're going to present to people, don't do it electronically. It's so funny. We're talking about telehealth. I printed off a map that I showed you the disc golf courses. I printed off like a 20-page document of like funding resources, the grants that we can apply to, the logistics of putting in a disc golf course, all of these different things I put into a presentation and I physically printed it off and I physically handed each one of the board members a physical copy of the course and my plans to put it in. And I think that was really powerful that I just didn't do it electronically. I sure could have. I could have presented on my laptop or presented on their PowerPoint there. But there's something about rural areas. There's something about, a handshake, looking somebody in the eye, telling them your plan, telling them your passions, handing them a physical document. And then when we're putting in the course, their park board members are out there and they're flipping through the document. Okay, this hole goes here, and this is the logistics. They got it right there in their hand. And there's something about that physical thing in the hand that really just means so much in these rural areas and small communities. So if you're thinking about community health initiatives like this, make something as simple as a flyer. It looks so prepared. If you come to me, like I do work at the Guernsey County Fair. I was very honored to get to go down there and do an abdominal aortic aneurysm screening. We did a AAA screening with the butterfly ultrasound as part of the Honors Ultrasound Project. We also did a Spot the Skin Cancer Day there. And you better believe I had printed off packets of health information, printed off packets of flyers, and being able to hand those to people, hand those to leadership, you just look so much more prepared if you can just say, hey, here's a physical flyer. And it doesn't have to be crazy. Hand them something. And you hand something to people in their hand, I think they remember it much more. And so that's how I would say how you engage your community and just network in these small communities. People really want you to give back. People are really excited when people are passionate about things. So if you got that passion, just reach out to somebody and just start networking. Hey, who do you know who's in charge of this or this and that, and see how far you can get. And I definitely think you'll go far if you just keep persistent.
Awesome. Thank you so much. I think that's all the questions I have and that everyone else has in the chat. So thank you everyone for coming and taking time out of your evening to join us. And thank you, Johnny, for this incredible presentation.
Hey, it's such my honor. I'm so blessed and honored to be here today. Thank you guys for joining, and I hope this gives you the passion to, as I say here on this slide, to finish this out. Is it going to be, oops, oh, we're going backwards. Is it going to be day one or one day. Win the day, my friends, and thank you guys for your time. I appreciate it.
Thank you.